This is a 9-year-old male with a history of asthma. 10 days ago, he was traveling to Alpine and developed persistent wheezing requiring frequent albuterol use. 3 days later, he was seen by his primary care doc and told to increase his flow vent dose. And later that day, he felt dizzy and fell while playing basketball. The next day, he developed fever up to 103, generalized body aches, primarily over the chest, legs, and hands. The following day, he appeared delusional and was smiling while quote, talking about things that don't make sense. Again, he was seen by his primary care doc. He was diagnosed with a viral infection at that time and told to take Motrin around the clock. He continued not to feel well and have periodic fevers over the next couple of days. On the day prior to presenting to the ED, he began to vomit and complaining of worsening generalized body aches. He was prescribed Tylenol with codeine, which did give some relief. Although he was hungry, or he was not hungry, he continued to take liquids well, but it was noted that he had decreased urine output and his urine was dark amber in color. So on the day of presentation, he developed a rash over his trunk and extremities. His breathing became faster and more labored, and he complained of neck stiffness and was noted to have altered mental status as well. The parents called 911 and PMS transported him to the Reilly ED. So this is the ED course. In the ED, he was placed on oxygen. His initial saturation was 85% on room air. He received 3 duonebs, a dose of 2 per kilo of IV solid Medrol, 2 20 cc's per kilo normal saline boluses, and a dose of ceftriaxone. And a decision was made to admit to the hospital service. So at this point, he's on his way up to the IMU.
As you can see on his chest x-ray, left side, a little bit of atelectasis. The final read shows that he has a left lobe atelectasis with mediastinal shift. This makes me worried because this patient is already in respiratory distress and now it's showing some sort of mediastinal shift. It could be due to the atelectasis. And the atelectasis itself is concerning because could he have some type of extrinsic compression of his bronchioles? He definitely could. He has persistent wheezing despite us treating him. Could he have an enlarged left atrium, hyaloadenopathy, some sort of other mass? So I start thinking in that direction as well. And this is not commented on, but the right upper side doesn't look completely normal to me. There's some lucencies here with some patchy opacities. So that's a little concerning as well. His head CT comes back. It is read as normal. He does have some paranasal sinus opacification, so I keep that in the back of my head, but overall reassuring. His chest CT now comes back. And here you can see that on the left side, he has a left-sided consolidation. He has these multiple pulmonary nodules kind of in the periphery that I was not expecting. Again, same kind of view, but now you can also see the hyalolymphadenopathy, same consolidation with the multiple pulmonary nodules. The official read comes back, varied size, nodular densities throughout both lungs, and hyaloadenopathy, concerning for an opportunistic infection such as granulomatous or fungal, less likely bacterial, especially in this patient with allergies and asthma. He has small bilateral pleural effusions as well. EKG is sinus tachycardia. Echo is reassuring, no valvular disease, normal function, so that makes me happy. So further clinical course at this point. His vital signs trend over the next 12 hours. He's persistently febrile. He's tachycardic to the 130s, better than the 160s, but still not perfect. He's still tachypnic, and his blood pressure starts to drop, so I'm getting even more concerned. He's now 94% on a 6 liters face mask, where he was 100% on 5 liters face mask prior. So he's sleepy and also difficult to arouse. Not looking too good here, and complains of more chest and leg pain. Next time we sit down, we get plain films back. These are all read as normal. The MRI comes back, and you can see right off the bat that on the right distal femoral metaphysis, there is a subperiosteal hemorrhage, as well as serpentine foci that are highly concerning for osteomyelitis. These are just cross-sectional views. Here you can see the moth-eaten appearance of the bone. Here you can see the subperiosteal hemorrhage. Here, with the abnormal enhancement of the muscles, you can see the diffuse kind of myositis. And you catch a view of the lungs, pulmonary effusions, and the pulmonary nodules are still present. So the MRI of the right hip and leg, this is the final impression, the hemorrhage, bony infarcts, osteo, the myositis, as well as a right knee joint effusion. Could be sympathetic, but can't rule out septic arthritis, and just generalized lymphadenopathy in the pelvic region and inguinal lymphadenopathy. So clinical course, he's intubated in the PICU. Orthopedics does an IND, and they grow GPCs in clusters. After the first culture came back, I asked for repeat cultures. The repeat culture was positive within 4 hours. Despite IV antibiotics, every culture I asked for subsequently continued to be positive. So this is my final diagnosis, Staphylococcus aureus, severe sepsis syndrome, and septic emboli secondary to osteomyelitis. And just in looking at the literature, the mortality rate for something presenting so severely, the mortality rate is near 64%.
So this is the final culture results that came back.